Thank you very much. Question to David, really. You talked about your 13 patients who you think you would still operate on now based on the Mars criteria. Don't we still have to demonstrate that those patients have a superior outcome to those patients who are treated with chemotherapy alone in that group of 13 people? Do you have the matched outcomes for an equivalent oncologically treated population, and can you demonstrate superiority? Because it's not about equivalence. We need to demonstrate superiority, don't we?
Well, you're a scientist, Leanne. You know about the power of a study, and 13 patients is nowhere near enough. All I'm saying is that there is a future for Mars 3. Look, it would be like doing a trial on lung cancer if you said, we'll operate on all stages of lung cancer, including N2B. We might include a few small cell, if they're stage 2 or 3, and we'll operate on them, or we'll give them systemic therapy. And guess what the result would be? It would be similar to Mars 2. And would we really be sitting here saying, well, that's the end of all lung cancer surgery? It's not rocket science. It's just that we did a trial in good faith, and it does show who not to operate on. But that's fair enough, but don't throw the baby out with the bathwater. Don't say there's no role at all for any surgery, because that obviates the intelligence of a surgeon being able to select the right people. So all I'm saying is, yes, it does prove a lot, and it does help us select who we should be operating on, and let's do the trial. I mean, I think there are enough people worldwide, and there's certainly the willingness to do it worldwide. I think we still need to answer that question. Let's not go too far, because we may want to do that in lung cancer, but let's not go there.
David, you mentioned that it is probably taking the diaphragm out, which explained high mortality. Every time I came to see you operating on these patients, you did advocate the diaphragm has to be removed. So 80% of the diaphragms were resected. Is that the practice even for T1, T2 disease to have the diaphragm resected? And how many actually in this trial were actually T1, T2 right at the outset and had the diaphragms removed?
Well, you can see in the trial it was a high proportion, and I'm quite happy to say that I've learned from that. And we've published a comparison of sparing the diaphragm against resecting it in the same stage of patients, and hey, what, there's a survival difference. If you take Granny's diaphragm out, and then she gets a chest infection, she's not going to do well. And as you saw that's what happened. We got them out of hospital. When they got home, and they got a chest infection, or they got COVID, for example, they didn't do well. And I think that may have been the problem with an EPP. It was taking out the diaphragm. And so I would backtrack on what I've published and said we should take the diaphragm, because I thought it was more important to get a macroscopic complete resection. You can still do that in early stage disease and preserve the diaphragm. I think it's the same as, doing a lobectomy or segmentectomy, or even doing a pneumonectomy or a sleeve. You've got to look at the balance that the effect of the surgery has on the patient against the cancer control. And I think we overdid it. We did too much, too late.
Yeah, but you're taking the parietal pleura out because we think that's involved. And if the diaphragm is not transmural, but you still have a layer there, how are you going to separate that? You're definitely leaving a disease behind there, isn't it?
No, you can ask the trainees that have seen me do it. You can do it. Okay. It's like taking the pleura off the visceral surface of the lung. It's the same.
Okay. Eric, sorry.
Just two things to say. One is that we had to adhere also to the ISLC uniform definition of what an operation is. And on EPD, that was what's specified. If it was involved diaphragm, then that had to go. And that was in the surgical. We also had, surgeons record or a script where they had to follow, and this is what the operation entailed. So we couldn't deviate from that. Otherwise, you'd be just doing your own operation. It wouldn't be standardized. With regards to selection, subselection, surgeons always say that, the art of surgery is selection. And would you say the same thing to the Boston group who just said that here's our selected outcomes with biphasic mesothelioma? They did awesome. Would you say that that's okay because you guys are amazing at selecting?
No, look, I'm not advocating that we have to. I'm just saying that there is still scope to look at the role of surgery in mesothelioma. What I'm objecting to is this term that all disease is unresectable, because I don't believe that's true. And that's a dangerous line to go down. Based on these results, you can't extrapolate from these to say that all mesothelioma is unresectable. That's the only thing I object to. Everything else you said is correct. and the groups were randomized, and the staging doesn't matter because they were randomized, but it's the overinterpretation of the results I object to.
Yeah, much clearer.
How did the survival statistics compare for the 20% of the cases who did not have their diaphragm resected and compared to the ones who went on the chemotherapy arm?
Now, I'm not sure I don't have a direct comparison.
Yeah.
The PD, the pleurectomy decortication patients, by sparing the diaphragm, that we've done since Mars 2, and it's published data, the 3-year survival is 57%, which is much better than the early stage diseases in Mars 2. I do believe that we did too radical an operation. And you can see why I say that, because they didn't die of the disease, they died of the cardiorespiratory effects after discharge. And also they weren't able to have any systemic therapy. And these are quite poorly people.
Thank you.
Any more questions on Mars? Yes, Akshay?
I've got a question for Professor Fennell regarding systemic treatments of mesothelioma. Is there any preclinical or early phase data looking at mesothelin-directed CAR T-cell therapy? And if so, how does it compare to checkpoint blockade? Or are there any other CAR T-cell directed therapies for meso?
Yeah. To the mic here. Yeah.
Thank you very much. Yeah, the CAR T treatment is a new approach really for trying to control, I suppose, mesothelioma, but it's very, very early days. We've had phase 1 data. I think one of the challenges we've got with mesothelin is that it's a protein that disappears. It disappears when the tumor forms from the epithelioid to the sarcomatoid variant, and it might actually be an escape mechanism causing resistance. You know, we've done a study actually targeting mesothelin using a chemotherapy-tagged antibody, and that was no better than chemotherapy. So I think there's interest in NK cell therapy as an alternative approach using the innate immune system. But at the moment, I'm not that excited by the mesothelin CAR Ts, I'm afraid. I think there may be some developments that need to happen first before we can be confident that's the way to go.
On that note, I'm here. I'm here. Sorry. The question I'm just asking is that if you have a patient and you've done the markers and there is a mutation and the PDL is positive, is your approach going to be different than what you advocated?
So, I mean, doing a randomized CAR T study is not trivial. And I think it'll be some time before we can see that type of sort of powered study, actually. I think when selecting for immunotherapy, there is some data that is emerging. We're publishing some. There are others who have been publishing data showing that the predictors of immunotherapy response differ significantly from other cancers. So people will talk about mutation burden as a very important, characteristic of the cancer that predicts for the immune response. And we don't see that in mesothelioma. It's a very low mutation burden tumor. And we've got some data that's just been accepted from Nature Communications suggesting that the gut microbiome is influencing the tumor microenvironment fundamentally, and that this interaction is what probably determines susceptibility. And in fact, if you look at the existing data emerging from some new studies, this is very consistent, I think, in terms of the immune microenvironment. So, there may be ways of looking for things like tertiary lymphoid structures, immune cell burden, and their configuration. That might be the best way to predict outcomes.
Right, Professor Rahman, it's your turn now. So the question that surgeons tend to use 8-gram talc during talc-pleuresis, is there any evidence that 8 is better or more harmful than 4?
Thanks very much. I don't think there's any evidence it's better. We've got now thousands and thousands of patients in randomized trials with 4 grams showing exactly the same sort of outcomes as were seen in the early surgical trials in the 70s and 80s. There was a methodological problem with some of those studies, which was the way in which the pleurodesis outcome was counted. So if a patient died and didn't get a recurrent effusion, that was counted as success. There's a problem with that, which is if my intervention kills everybody on day 1, then I have a 100% success rate. So we have to be careful about that. Is there a problem, however, to balance this with 8 grams of graded sterile talc? No, I don't think there is. My colleagues in Oxford use 8, sometimes 12 grams. We're not seeing lots of ARDS. The longer-term outcome problems with talc, I know there was worries about mesothelioma in young patients. There's large-scale data from physicians giving talc to young pneumothorax patients at 8 or 12 grams, showing no ARDS and no long-term problems with malignancy, as far as we know. Now, those studies started in the 80s, so I guess we're at the 30, 40-year mark. Maybe in 2030 we'll get a load of mesos, I don't know. But as far as I'm concerned, I mean, I'm not wedded to 4 grams particularly. I actually just use 2 bottles because my fellow spills half of it in the operating theatre. So I suspect it ends up at about 6, but I'm not too wedded to a number.
Yes, Babu.
I've got a question for the non-surgeons on the panel. What is their take on surgery for mesothelioma post-Mars 2? Both from the GVAN.
Thank you. Dean, shall I be the idiot going first, do you think? Yeah. What's my view? So can I say a couple of things? The first is I think we, as non-surgeons, have the most enormous respect for your community for doing these studies. These are not, I'm a clinical trialist. I know how hard studies are to do. We mess about with IPCs and talc, and that has given me, caused me massive hair loss and grey hair and all that already. Let alone doing a surgical trial. So Mars, Mesovats, Mars 2, massive kudos for your community coming out and asking difficult questions and doing it. That's my first point. My second point is no study is perfect, regardless of the journal in which it gets into. So even New England Journal studies can and should be criticized. And it is inevitable that after you've done a study, people will line up and say, but I could have done it better. And the fact is they couldn't because they didn't do it. So we should say, accept a study and say it's perfect and we move on. It's reasonable to criticize, but you'll always get criticized. I'm trying to provide some psychological support for Eric at this point, clearly. But having said that, my view, and this may not be popular in this room, you have 3 randomized studies in mesothelioma surgery, 3 in total, Mesovats, Mars 1, Mars 2. There is at no point in any of those 3 studies any evidence of benefit of surgery. That is very clear. I don't think David or anybody else disagrees with that. It's pretty true in Mesovats. Okay, it's true if you are one of the 15% that survived to a year to have an increased quality of life, which is fundamentally flawed, and you spent a lot of today criticizing numbers, and so it's the same criticism. So it really, I think, coming back to a colleague's point about superiority and non-inferiority, my view as a clinical trialist but a non-surgeon is that you need to show evidence of benefit in a randomized trial. And that I haven't seen. My own view is, I think David may be right, there may be a selected population who benefit, and I can take the argument we should do a smaller intervention and PET staging and mediastinoscopy. That will leave you with a smaller group. But then sure, let's do a randomized trial. But I think, this is the controversial bit now, David, apologies. I think that surgery should only be done as part of a randomized trial. That's my own view.
Thank you. Before we leave, sorry.
I'm just going to echo what's been said, actually. I think the problem I've got as a trialist is that where you change the selection criteria of a subgroup, you may change the prognosis. So everything that's been described, the tumour, the nodal status, etc., these are all prognostic factors, and yes, patients will do better. And I just want to echo the point I think that Raj has made, actually, that it's in the randomized context that you can see what effect this is going to have on the other arm, and therefore determine whether or not there is any superiority at all, or whether you're just making everybody better. And we have some patients in our practice, for example, who we don't treat at all. We watch them. They have very benign, indolent disease, and we can continue to survey them. Sometimes, I think the longest is 7 years that we've had with no intervention. So yeah, if you do select, you might be selecting for a better outcome anyway, and you'd need to do it in a randomized setting.
Before we wind it up, delegates would like to know from Professor Kasivi, what is your practice at Mayo?
Fair enough. I think, first of all, I want to congratulate the 4 speakers. They were excellent. And I want to say to Eric and to David, thank you for not pulling any punches. No, this is one of the wonderful things of this conference, is that you get people toe-to-toe able to speak about the issue. And this is what we come to these meetings for, so that we can have a full, honest, unvarnished discussion. So thank you. We in North America, I'll say in North America in general, but specifically at Mayo, we've learned from the studies done here in Europe and in the UK, Mars 1, Mars 2 specifically. I will say we still do operate on mesothelioma, much to what David has spoken to. We're very big sticklers, because we have a background at Mayo now that is very Toronto-centric, which is Bob Ginsberg, and we still do very strong staging. So they'll get mediastinoscopy. We don't feel there's a role for mesothelioma once you have N2 disease. We don't operate on non-epithelioid. And as David very aptly put it, I think there is a reality that we often do too much too late. And it's in that context that we do select our patients. And I'm one of those surgeons, and maybe that's again a blasphemy, but I'm one of those surgeons who is actually proud when someone tells me that my cohort is well selected. That's what we do as surgeons. And I think these randomized trials inform us, they educate us, they tell us what we should or shouldn't do, but I think they inform us on how best to select that individual patient that comes in front of you. We're not medical oncologists, forgive me, if there are any left in the room, who are very stuck to randomized trials. I can't treat that person, we don't have a trial to tell us what to do in those situations. We're surgeons, sometimes we have to deal with a patient who falls outside of a criteria, and we have to do selection. So I would encourage you to look at the studies, be analytical, as Eric and as David have done, but also look at the patient that's in front of you and honestly assess whether that patient, what's the best treatment for that patient, whether you should do it, whether someone else should do it, or whether there's a different type of treatment that they should get. But short answer, we still do operate on selected mesothelioma.
Thank you.
So I think we'd like to close the session. Just a reminder that there is, we'd like to thank all our speakers for excellent talks and excellent discussion afterwards. There is a welcome reception which is being held in the exhibition hall. I believe it's starting about now. Okay, so I hope to see many of you there.